So we are continuing with our discussion of GI pathology. GI pathology is the fun part, right? Anatomy and physiology is boring. Everyone agrees on that. And then the pathology is fun. So we talked about esophagus, talked about infectious esophagitis, and the three main parts, or three main types you need to know: candidiasis, herpes simplex esophagitis, and CMV esophagitis. These are all going to be found in your HIV patients. It says elderly and immunocompromised, but for the most part, for step one, really look for AIDS. Right? Look for AIDS in the question stem. And so could you tell me, I'm going to go ahead and label these three images. Okay, this is A, this is B, this is C. If you could please tell me which of these is candidiasis, which is herpes, and which is CMV. Uh-huh. Yes, correct. Candida is A. Candida, herpes simplex, and CMV. Yes, herpes. Uh-huh. Yep. Yes. Very good. Very good. So Candida is going to be A, HSV-B, and then CMV-C. And the big thing, I think, with the difference between herpes simplex and CMV, those are the ones that really you could really possibly get them confused how they look. Remember that there's a bit of a raised edge to these lesions in the herpes simplex, whereas the CMV, it looks basically like a big punched out ulcer. So if you were to look at it from the edge, for HSV, the ulcers look a bit like this. For CMV, the ulcers look a bit like this. Okay? And that's going to be your major way of telling the difference. Okay. So treatment. What sort of treatment can we use for herpes? What is the one drug we always use for herpes? Acyclovir. Yeah. Excellent. Acyclovir is our go-to drug for herpes. Now, they sometimes will ask you, how does acyclovir work? And then it's like, whoa, I already knew what herpes looked like. I already knew the drug to treat it. Leave me alone. I'm done answering questions on it. But no, then they take it another step. How does acyclovir work? And so the way that acyclovir works is it once your patient takes the drug, it gets metabolized by the liver. It will be taken up by some of those cells that have the virus inside. And as the virus is trying to replicate its DNA, acyclovir is going to look like a nucleotide. So the virus is going to take acyclovir, try and put it into its new viral DNA. However, once it uses acyclovir as part of its DNA, it will not be able to continue making any more DNA. The reason is because it lacks the phosphate group. Lacks the phosphate group. And so it cannot continue out that chain of DNA as it's synthesizing DNA. Okay? So that is the way acyclovir works. It essentially gets incorporated into the viral DNA, and once it's incorporated, the virus cannot continue making DNA. So it works nicely for that. But just like anything else concerning herpes, yes, you will stop having these episodes of esophageal herpes. However, it's just in remission. So if you ever stop acyclovir, it's going to come back. Okay. And so that's one thing with herpes, is that it always stays latent somewhere in one of the ganglia, waiting to come back as soon as you stop the medication. Okay. And so great. I'm happy that you told me the drug for HSV. And because of that, I'm going to tell you the drug for CMV, unless you know it. It's similar name. called gancyclovir. Gancyclovir. Gancyclovir is very similar to acyclovir. That's why they have similar names. It's used to treat CMV, and it works in the same way. Okay? It's just a little bit different to make it better for use against that CMV, but it works in the same way, and it can be helpful in these patients. Okay? Great. So, moving from our esophagus into our stomach. You cannot talk about the stomach without talking about what happens when you have too much acid. The stomach makes acid, the parietal cells. It is their job to make acid. However, acid, as you know, is very acidic, right? So, that acid can cause damage to the stomach mucosa. We call that acute gastritis. Acute gastritis happens whenever there's an imbalance between the mucosal defenses, meaning mucus, meaning any protective lining that the stomach has, and the acidic environment. We want to have a good, strong acidic environment because that's how we're going to start breaking down some of the proteins. That's how we're going to kill some of the bacteria and viruses that are in the food that we eat. We need that very strong acidic environment, but we also need defenses. So mucin layer is produced by foveolar cells. These are a cell type within the epithelium of the gastric lining. Bicarbonate secretion by surface epithelium, normal blood supply. Having a loss of any of these three things can cause gastritis, and I really want you to pay attention to this one, normal blood supply. It's one that you don't really think about. What does blood supply have to do with acidic damage to the stomach mucosa? But if you're not supplying those protective cells with a good supply of blood, then those protective cells cannot do their job, and you're going to have acidic damage. Okay, so some of the risk factors for gastritis: if you have a severe burn, this leads to hypovolemia. Hypovolemia leads to decreased blood supply. Decreased blood supply leads to gastritis. That's what we just said, right? A decreased blood supply means we can't have that protective barrier. So any patient that you have that loses a lot of blood, they should probably be put on some sort of proton pump inhibitor drug. Because we know if you lose a lot of blood, your stomach is going to lose its protective lining and you're going to develop gastritis or even ulcers. Okay? This type of ulcer, so you have a patient who gets a burn, right? Say they spill some boiling hot water on themselves and it covers half of their body. It was a big pot of hot water, right? It covers half of their body. They're now in the ICU. Okay? And they're in the ICU. So, because of that severe burn, they develop hypovolemia. That's what happens in burn patients. They develop hypovolemia. That leads to the decreased blood supply, and that leads to an ulcer in the stomach. Okay, be able to connect those dots. This is called a curling ulcer. The guy that discovered it, his name was something curling. But the way that it helps me remember this is I think of a curling iron. Right? From a curling iron, you can get a burn. I don't need a curling iron, obviously. But my understanding is from a curling iron, you can get a burn. Burn makes me think of severe burn, makes me think of this severe burn leading to gastritis. Okay. Any patient that is taking aspirin, ibuprofen for an extended period of time, aspirin and ibuprofen, they block the COX pathway. The COX pathway is responsible for synthesizing prostaglandins. If you have decreased prostaglandins, you're going to have decrease of your protective lining. Okay, so when it comes to gastritis, think about patients that are taking aspirin and ibuprofen for long periods of time. Alcohol consumption, chemotherapy. If you have a patient that has some sort of head trauma, increased intracranial pressure is called a Cushing ulcer. So that increased intracranial pressure stimulates the vagus nerve. Vagus nerve, remember we looked at that diagram that showed all of the ways that we increase acid in the stomach. That was in our last lecture. So some of the ways that we increase acid, we said that gastrin increases acid. We said that stimulation of the parietal cells increases acid. We said histamine increases acid. Anything else? That was pretty much it, I think. So those things all increase acid. And what stimulates all those things? The vagus nerve. So you have a head trauma. That leads to increased intracranial pressure. That pressure leads to stimulation of the vagus nerve. That vagus nerve is going to trigger the stomach to make more acid, and you end up with the Cushing ulcer. Cushing ulcer, okay? The way that I remember this is that you should have had some cushion on your head so you didn't get the head trauma, right? Cushing ulcer. Other things, shock can result in stress ulcers. This can also be seen in ICU patients, just like our curling ulcers, okay? So this acid damage results in superficial inflammation, erosion, and can result in an ulcer. So that's our acute gastritis. That's our patient that did not have gastritis before. Boom, all of a sudden they have gastritis. What about a chronic gastritis? What about a gastritis that is going on and on and on for a long period of time? And so where there's two general types of chronic gastritis. That's pretty easy to remember, right? Just two types. There's our type A. A stands for autoimmune. Always remember that. Type A gastritis is our autoimmune gastritis. And type B is our H. pylori gastritis, right? H. pylori kind of sounds like B. H. pylori gastritis. So let's talk about type A first. Our chronic autoimmune gastritis. Here we have autoimmune destruction of parietal cells. That does not sound good, right? So what do parietal cells make? Why do we care about parietal cells? So there's two cell types in the stomach we talked about last time. Right. Intrinsic factor, good, yes. Intrinsic factor, and they also make acid. Right? Parietal cells are the ones that are actually doing the work. The chief cells, they call themselves chief, but they're not the chief, okay? They pretend to be chief. They're not the real chief, okay? The real chief is the parietal cell because they make what matters. They make intrinsic factor and they make acid. And so if we have an autoimmune destruction of these cells that make intrinsic factor and acid, we're going to have problems, right? So what do we see? Well, we have atrophy of the mucosa. That makes sense. Achlorhydria. This word means lack of acid. Achlorhydria equals no acid. No H plus means no acid, right? Achlorhydria, we have increased gastrin levels. Gastrin is trying to stimulate those parietal cells to make acid, right? But those parietal cells cannot because they're being destroyed. So we'll see low acid with increased gastrin levels. And we'll even see a hyperplasia of the cells that make gastrin. Okay, so all of these terms you need to be comfortable with and familiar with. It's great that you know, yes, type A means autoimmune. It means I'm losing my parietal cells. But I also want you to know, so we lost our parietal cells. What happens next? One of the things that happens is that the G cells that make gastrin start to multiply. They recognize that there's no acid being made. So they're saying, okay, I'm a G cell. I make gastrin to increase acid. I'm looking out. I'm not seeing any acid. Let me make more gastrin. Still no acid? Let me make more gastrin. Still no acid? Let me make more gastrin. Still no acid? And then it just keeps going on and on and on until these cells start to multiply. Okay? So that's what we see. Megaloblastic anemia due to lack of intrinsic factor. Okay, and so this gets us into our macrocytic and microcytic anemias. For our macrocytic anemias, B12 deficiency is one of the big macrocytic anemias, right? B12 deficiency. We've lost our intrinsic factor, and so it makes sense we've lost our B12. And so this will be one of our macrocytic anemias. This is what's called pernicious anemia, and that's just a fancy word meaning it's our B12 deficiency anemia because of autoimmune gastritis. Okay? So when you see pernicious anemia, think about autoimmune gastritis. When you see pernicious anemia, think about autoimmune destruction of those gastric parietal cells. Okay? Great. And I'm not going to tell you to write that down, but if you're listening to this, your second time going around, write this down. Okay? Otherwise, increased risk of gastric adenocarcinoma. So there's increased risk of cancer in this particular type of gastritis. Okay? So that's pretty important too. So when we have this autoimmune destruction of our parietal cells, we look for loss of intrinsic factor and loss of acid and all of the things that would show up if we lost those two things. Okay, great. So type B, this is due to H. pylori. This is the bacteria that loves acid. H. pylori can cause acute or chronic inflammation, and it's our most common cause of gastritis, 90%, pretty common. And so H. pylori, like we said, has lots of enzymes, ureases, proteases, and inflammation that weaken mucosal defenses. And the most common site of having this infection is the antrum. Okay, so let's look at this image. Where is the antrum? So I see the cardial notch, I see the fundus, I see the cardia, here's the body, boom, there we are, antrum. Okay, and so when we think about H. pylori gastritis, I want you to think about that gastritis happening right here. Boom, right here. Okay, and just to take a step back, let's look at where type A gastritis happens. It says stomach, body, and fundus. Okay, so let's look at where the body and fundus. We have cardial notch, cardia. Okay, here's fundus. So type A will happen here. And body. Okay, type A will happen here. That is different. That is a different area than type B. Type B is in the pyloric antrum. Type A is in the body and fundus. Okay, why am I focusing in on this? I had a question that talked about type A gastritis and then labeled the stomach and asked me to pick a label that corresponded to where the gastritis would be happening. Okay, and so this is why I'm focusing on it. When you see H. pylori gastritis, think about the antrum, which is the area right before you get to the pylorus. Okay, and then you get into the duodenum. Great. So how do these patients present? Epigastric abdominal pain. They have a risk of ulceration, gastric adenocarcinoma, malt lymphoma. Treatment is going to involve triple therapy. Triple therapy will reverse that gastritis, reverse the intestinal metaplasia. And in order to test for this, we will do urea breath test and look for stool antigen. Okay, so urea breath test is how we test for H. pylori. Once we have a negative urea breath test and lack of stool antigen, then we know H. pylori is gone. It is gone. Okay, great. So it looks like a crazy person did some writing on this slide, and that may be the case. Do you have any questions on this? No. Okay, great. Okay, so good. Yes, just pointing out again, pyloric antrum for H. pylori, and then the body and fundus for chronic autoimmune gastritis. Okay, great. And so just really getting into some of these differences as well. I also wanted to point out that for our autoimmune gastritis, this is an autoimmune condition, meaning we have B cells getting involved. We have T cells getting involved. We have antibodies floating around in the serum. Whenever we have an autoimmune condition, we always need to know the antibodies we test for, right? And that goes for any autoimmune condition. So this is no exception. For autoimmune gastritis, the ones we test for are anti-parietal cell antibody and anti-intrinsic factor antibody. Okay, and these make sense, and they help us to reinforce what's happening in this condition. In autoimmune gastritis, we have an attack on our parietal cells that causes us to lose intrinsic factor. So why don't we test for antibodies against parietal cells and antibodies against intrinsic factor? And that makes sense. Okay, great. So moving on, our peptic ulcer disease. Here we have a solitary mucosal ulcer. Tends to involve the proximal duodenum. We say peptic ulcer disease, a lot of times it makes you think of stomach, but 90% of the time, believe it or not, it's actually an ulcer in the duodenum, in that first part of the duodenum. Okay, and only 10% is in the stomach, which you can see here. So duodenal ulcers, these are always going to be due to H. pylori. Why does H. pylori infection here in the antrum cause an ulcer all the way over here? You would think, okay, I have a bacterial infection. Wouldn't the bacterial infection cause an ulcer right here? See, this is the way that they're going to trick you. One thing that I kind of breezed over when we did gastric physiology We talked a lot about the parietal cells and the chief cells over here in the body and fundus, but I didn't tell you too much about the cells here. The cells here are actually pretty important because the cells in this area are going to be the cells that create mucus and bicarbonate. These cells create mucus and bicarbonate, and all of the acid that's coming down, trying to get to the duodenum, before it reaches the duodenum, it's going to mix with mucus and bicarbonate from this area, so that when all of this nasty mix reaches the duodenum, it's not too acidic. The duodenum has a very, very gentle lining. So we don't want things that are too acidic going over there and causing problems, okay? And so this area here is responsible for making mucus and bicarbonate. Now, what happens if H. pylori comes in here and starts throwing chairs around and breaking everything? Now we're going to lack that mucus and bicarbonate. Now acid coming down from the stomach into the duodenum, that acid that hits the duodenum is going to be very acidic, and so that's where we're going to end up getting our ulcer, right there at the first part of the duodenum, as all of this food that's mixed with acid is coming down here, and it's not being deacidified by the antral area. Okay? Does that make sense? Why you see it in the duodenum and not the stomach? Okay, good. So, a duodenal ulcer, always due to H. pylori. H. pylori causes that infection. It results in loss of bicarbonate. Okay. Now, if you see a single ulcer, think about H. pylori. If you see more than one ulcer, I'm not talking 6, I'm not talking 10, I'm talking even if you see 2 ulcers, the answer on step 1 is Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is a gastrinoma. Gastrinoma. Meaning, it is a tumor that secretes gastrin. If you have a tumor that secretes gastrin, either in the pancreas or somewhere in the duodenum, the parietal cells of the stomach are going to increase the amount of acid that they're secreting. All that acid is going to hit the duodenum and give you multiple ulcers. Okay? And so, if a question on step 1 ever tells you there's more than one ulcer, you can be like, thank you so much, Jesus, for giving me this very easy question, because I know the answer is Zollinger-Ellison syndrome. Right? Zollinger, you know this one, right? I don't have to spell it out. Zollinger-Ellison syndrome. And that Zollinger-Ellison syndrome is essentially you have a tumor that is secreting gastrin, and that's what you see. Questions on that? No? Okay, good. So, duodenal ulcers, they always ask about when is the pain, what makes the pain worse, what makes the pain better. For duodenal ulcers, the pain improves with meals, okay? And the reason is, once you start having a meal, you're going to have the pancreas down here, and that's going to be putting out bicarbonate. You're going to have, some other factors here that are helping relieve the inflammation, okay? So when these patients eat, they feel better. So these patients tend to gain weight, okay? They tend to gain weight. Their pain goes away when they eat, so why not eat more? Tastes good anyway. These ulcers do not need to be biopsied. This is a question on your step 1. You do not need to biopsy duodenal ulcers because 99.99% of the time, they are not going to be cancer, okay? They're also not going to have any H. pylori because the H. pylori is all the way back here in the antrum, okay? So your biopsy is not going to tell you anything. So do not biopsy duodenal ulcers. I repeat, do not biopsy duodenal ulcers. The problem with duodenal ulcers is that you have a giant artery right behind them called the pancreatico-duodenal artery that we talked about before. You told me about it last time we met. And this pancreatico-duodenal artery is a branch of the celiac trunk, well, a branch of the common hepatic, and so it has a pretty good blood supply. If this ulcer keeps going through the lining of the duodenum and ruptures that artery, your patient can start bleeding very quickly and bleed out very quickly. And so this is why we are concerned about it, and we do want to treat them. How would we treat these patients? What would we want to give them? Yes. Good. Yeah. Mm-hmm. Yep. Yeah, no, good. So typically it's going to be 2 antibiotics and a proton pump inhibitor. Yeah, good. So that once you treat the H. pylori, the ulcer will go away. That's the beautiful thing about it. So we can easily get rid of these ulcers using an antibiotic, which is pretty cool. Now, gastric ulcers, usually H. pylori, but again, we said that NSAIDs can cause gastritis. We said alcohol. We said burns. We said being in the ICU. There's a lot of different causes for those particular that chronic gastritis, and so for gastric ulcers, it includes those things. Now, the big thing here presents with epigastric pain that worsens with meals. And this one I always feel comfortable remembering because think about it. You have food that is falling onto this bright red flaming thing. That's going to hurt, I think, right? That's not going to feel good. So these patients tend to get skinnier. They tend to lose weight because they don't want to eat because it hurts. Okay? These you do want to biopsy. There is a risk of cancer from gastritis we talked about before, and so you do want to biopsy these ulcers. Okay, great. So moving from the stomach to the small bowel, the job of the small bowel is to absorb all this junk that we eat, and so when we have problems absorbing that food, that's what we call a disease of malabsorption. And so that disease can either be part of things that happen within the lumen while it's inside the lumen of the intestine, or things that happen in the cells themselves that are lining the intestine. Okay? So the first one we will talk about is cystic fibrosis. Cystic fibrosis we always associate with the lungs, but there's a pretty big problem that happens with the pancreas. So the classic defect in the CFTR gene, we have to know that. This leads to defective chloride secretion. Ultimately, this is going to have defective luminal hydration in the pancreatic ducts. Okay, so inside of the pancreas, it's not going to have enough hydration. There's not going to be enough water inside of these ducts. Because there's not enough water, things are going to start to condense. Right? It's not hydrated enough. Things are going to condense. You can think about the pancreas getting constipated, basically. As the pancreas gets constipated, it's going to start digesting itself because all of the enzymes backed up are enzymes that can break down pancreas. And so this is what we can see. Okay, insufficiency of pancreatic enzyme secretion. So look for these patients to be having deficiency of their fat-soluble vitamins because they can't really break down the fats too well. Look for, fatty stools. Just look for general malabsorption. These patients should be having a lot of diarrhea. And again, the mutation in the CFTR gene is on chromosome 7. Okay. So when it comes to malabsorption of the pancreas, there's this thing called the Dxylose test. Okay. So the Dxylose test will tell you whether your malabsorption is due to a problem in your pancreas or whether the malabsorption is due to a problem in your intestine. And so a patient comes to you, Natalia, a patient comes to you and says, I've been having very nasty diarrhea for a few weeks now. And then you go and check all of their labs and you discover that they're deficient in a lot of their vitamins. And so you say, okay, Mr. Patient, I know that you have malabsorption. What I don't know is if that malabsorption is due to a problem of the intestine or that malabsorption is due to a problem of your pancreas. The intestinal lining, if you talk about the duodenum, here's our duodenum. All of the cells that are lining the duodenum, they have enzymes in them. And those enzymes participate in absorbing sugars. So in absorbing certain sugars, The intestinal lining will be responsible for that. Okay, there's enzymes here, and so for certain sugars, they will be absorbed directly by the intestinal lining. Okay, but then for other things, we need enzymes from the pancreas. And so if it's a protein, some other complicated sugars, that requires enzymes to come into the intestines, and then that sugar can be absorbed. Okay, so what we do is we say, we know you have a problem either in these cells that are lining the intestines or a problem in your pancreas. We know there's a problem in one of those two things. We don't know where. I'm going to give you Dxylose. I'm going to give it to you orally. Dxylose gets broken down by these intestinal enzymes. And so if I give you Dxylose and then I check your urine tomorrow and there's Dxylose in your urine, that means you were able to absorb it through your intestines. So your malabsorption problem must be the pancreas. Okay? However, if you give your patient Dxylose, you check the urine the next day and you don't see any Dxylose, that means that this Dxylose went right past these cells in the intestine and continued on and did not get absorbed by the body. So the problem is here in the intestinal cells. Okay? So let's look at what the text says. We have malabsorption. We give Dxylose. If it's due to a pancreatic disease, that means that we absorb the Dxylose and we see it in the urine because we don't need the pancreas to absorb Dxylose. If instead we have a problem with the intestinal lining, that means we would not absorb any Dxylose, which means when we test for Dxylose, it would be abnormal. We would not see it in the urine. Okay? So this was something that I struggled with, and that's why I'm kind of like focusing in on it now, because it does get asked about, and I'm sure you're going to see it when you do your year-old questions. I always thought about it backwards. I always thought about an abnormal Dxylose test, meaning it's a pancreatic disease, but that's not it. An abnormal Dxylose test means that there's an intestinal problem. So you can think about Whipple Disease. You can think about Celiac sprue. A lot of these diseases that affect the lining of the intestine rather than affecting the pancreas. The pancreas is completely fine if you have an abnormal Dxylose test. Okay? Excellent. So moving on to celiac disease. Celiac disease, these patients are gluten sensitive. And this is an immune-mediated enteropathy, meaning a problem in the intestines, triggered by foods containing gluten. So gluten is in, a lot of different types of breads. It's in yeast, bagels, you name it. All of these different types of foods contain gluten. And so these patients really need to stay away because gluten will activate their immune system and cause them to have inflammation. Okay? So gluten is a protein, contains gliadin. You do need to know this. Gliadin causes inflammation in celiac patients. HLA-DQ2 and DQ8 is the genetic linkage. Okay, so definitely remember those. Those I remember being important. Serology also is important. I'm going to put another star here. I know I'm just killing it with the stars right now. So anti-TTG-IgA. They'll write it as this anti-TTG. Anti-tissue transglutaminase. That is seen in celiac disease. Okay. And an anti-endomysial IgA. And so when we take some biopsy, what we see is chronic inflammation, loss of brush border, villus blunting, and lymphocytes in the epithelium. Okay? So let me ask you. You have a patient with celiac disease. They're having some malabsorption. They've been having diarrhea. They're having malabsorption. You decide to do the Dxylose test. Are you going to have a normal Dxylose test or abnormal Dxylose test? Excellent. Very good. Very good. Abnormal Dxylose test because it involves intestinal lining. Yes. So proud. Good. So moving right along, this is what our histopathology looks like. You can see a lot of little lymphocytes in here. You've seen the regular intestinal lining before. It's nice thin villi like this that are not attached to one another. However, here you see that all of these villi are sort of connected, merged together, and a lot of lymphocytes inside. Okay, we call this villus blunting. So, moving right along, next disease we can talk about is our Whipple disease. And so this is an infectious disease caused by your Trophorema whippleI, okay? And we're going to look for something called Whipple's triad, which is diarrhea, weight loss, and arthralgia. We're going to have pain in the joints, right? If you have a patient with diarrhea and weight loss, you wouldn't expect them to also have pain in the joints. And so that's one of those things that's kind of high yield because not a lot of other things present this way. With diarrhea and joint pain, that is pretty specific for Whipple disease. And so that's something that you should be thinking about as you're reading through your first aid book. You see something bizarre like this. Whoa, diarrhea and joint pain, that's weird. Let me put a star there because that's going to help me remember when they give me the question stem, and that's how they're describing the patient. These patients can also have involvement of cardiac valves, leading to murmurs, and they can also have early dementia. Okay, and so you can see how Whipple's disease is just this very strange condition, right? We have a bacteria that's causing, joint pain and diarrhea and giving you dementia. Very strange picture, and so make sure that you keep this in mind on your differential when, if it pops up on a question stem. Pathogenesis, what is happening here? So we have macrophages that are gobbling up all of these bacteria. However, as they're gobbling up, they're not really able to break it down fully. And so they start to accumulate here in the lamina propria, in the mesenteric lymph nodes, and they end up obstructing the lymph ducts. Lymphatic obstruction is a big thing here. And so you can see in this image all of these big clouds, these nests of cells, they are collecting and causing obstruction of the lymphatic transport. Okay? So diarrhea, steatorrhea, all things that you can see here. Fatty stool. Okay? And this is going to be PAS stain positive. This is a stain for sugar, and it happens to be positive in Whipple's disease. Okay? And I'm going to put a star by this because that is one thing that you need to know about Whipple's disease. It's PAS positive. Okay? Next is our carcinoid tumor. This is a tumor that can arise from anywhere in the GI tract, but is going to be most common in the small intestine. Carcinoid tumor produces serotonin. It's just a tumor that produces serotonin. That's all it is. It's a fancy name for a tumor that produces serotonin. What does serotonin cause when it gets in the bloodstream? Flushing, sweating, spasming of the bronchi, abdominal pain, diarrhea, fibrosis of the right cardiac valves. Okay? And so, presence of all of these things means that there's been some metastasis as well, possibly to the liver. And so when you see carcinoid syndrome is flushing, sweating, bronchospasm, abdominal pain, diarrhea, right cardiac valve fibrosis. Now, when you see this, you're going to want to say pheochromocytoma. I already know. You're going to see that flushing. You're going to see that it's coming and going, and you're going to be like, oh my God, this is pheochromocytoma. But you're going to be wrong if you pick that. Why? In pheochromocytoma, there's headaches and there's high blood pressure. In carcinoid syndrome, there's no headaches, there's no high blood pressure. Okay? That's going to be how you differentiate it. The high blood pressure piece is really big. If you see high blood pressure, that should push you towards pheochromocytoma, versus carcinoid is really more of just this flushing and gassiness, abdominal pain, diarrhea type picture. A GI picture is very big for carcinoid. Okay, does that make sense? Yeah, good. This is associated with MEN1 syndrome, and because of overproduction of serotonin, patients may become deficient in a certain water-soluble vitamin, and so this kind of gets us back into our biochemistry. Some of our vitamins, we have to get all of them from exogenously. We have to consume them all in our diet. Some of them we can actually synthesize. When we get them in our diet, we use them to synthesize some of our neurotransmitters, like serotonin, for example. And so the vitamin that we need to synthesize serotonin is going to be niacin. Vitamin B3. Okay. And so, if you are overproducing serotonin, that is going to use up all of your niacin. You're going to end up with B3 deficiency. Okay. And so now, I know we're taking a little bit of a detour, but what does B3 deficiency look like? What does niacin deficiency look like? I will give you a clue. There are 3 Ds that you need to look for. Sorry, I can't hear you. Oh, three. It's the 3 Ds of B3 deficiency. So B3 deficiency is going to be, I'll give you one of them, diarrhea. Diarrhea. After you have your diarrhea, you're going to start to develop dementia. Okay. And if you have diarrhea and dementia, the only thing that's really worse than that is going to be death. Okay. And so vitamin B3 deficiency, niacin deficiency, you may have also heard this referred to as pellagra. Oh, really? Yeah. Yeah, so pellagra is the same thing as all of this. It's a deficiency of niacin, and this is how your patients are going to look. They also have some skin findings too, right? Some sort of dermatitis, I think, is another D that you can add in there. Okay? Good. So that's how all of these things connect. Your carcinoid tumor is making serotonin. Serotonin is made from niacin. If you're overmaking serotonin, you run out of niacin. Running out of niacin means pellagra. Pellagra. Right? Okay. Great. And so this is sort of your natural history of carcinoid tumors. Unfortunately, because a lot of times your patients do not have symptoms of their carcinoid tumor until it metastasizes. The reason is because, so your, let me just, do I have a blank slide? No. So here's our little carcinoid tumor, right? Carcinoid tumors tend to happen around the area of the ileum. So here's the ileum, which is the last part of our small intestine. Our carcinoid tumor is going to be making serotonin, and dumping it into the blood supply. All of the blood supply leaving the ileum is going to go to the liver. Okay, here's our liver. So all of that serotonin is going to the liver. When that serotonin gets to the liver is going to do its job. It's going to detoxify. It's going to get rid of all that extra serotonin. And because of that, our patient's not going to have any symptoms. So they have this huge carcinoid tumor just hanging out in their intestines. And your patient has no idea because the liver is doing its job in detoxifying, getting rid of all the extra serotonin. Okay, so now this tumor is getting bigger and bigger, and now it learns how to metastasize, and we have this little metastasis that goes through the bloodstream in that same direction, and now we have a carcinoid metastasis in the liver. Now, when this metastasis is making serotonin, that serotonin is going directly into the bloodstream. Now your patient starts having that flushing, starts having diarrhea, starts having that fibrosis to the valves. And at this point, it's essentially too late, right? Because the metastasis has already happened. And so if you look at this, what this diagram is trying to show you, we have years here on the bottom, and you can see that the tumor is growing over the years. And your patient may have some vague abdominal symptoms, but nothing really substantial that you would diagnose, right? Patients come in saying, oh, I get diarrhea. You're not thinking, oh my God, you have a tumor, right? That's not the first thing you think. You think, oh, okay, we'll try and change your diet, try and eat more fiber, these types of things. And so that tumor is growing and growing while they have these vague symptoms. Now the tumor metastasizes. Once it metastasizes and those mets start to grow, now we get our flushing. Now we get our diarrhea. And at this point, we make our diagnosis, but it's already too late. All right, it's already too late. And so that's why it's important that we learn about carcinoid syndrome. And so it's on our differential, sort of in our back of our mind, if we start to see some weird symptoms that we don't expect, maybe something else is going on. Okay? Any questions on carcinoid, Natalia? Okay. Great. So now we can move from the small bowel into the large bowel. So Crohn disease. In Crohn disease, Crohn is one of our two types of inflammatory bowel disease. They are both, associated with some genetic predisposition, and they're both sort of lifelong things that patients have to deal with. But they both look a little bit different, both in how your patient presents, what the long-term outcomes are, what the long-term treatment strategies are. And even when you do a colonoscopy and you look inside the colon, like we have right here, it looks a little different, Crohn's versus ulcerative colitis. And so those differences are what are going to be tested on step one. So for Crohn disease, what we see is a full thickness inflammation of the wall of the colon. So here's our normal colon, and here's the lumen. And so in the wall, we have muscle, we have glands, we have lymph nodes, we have all types of cells to help us with that colon phase of digestion. In Crohn disease, what we see is a full thickness inflammation with knife-like fissures, meaning the entire wall is involved here. The entire wall, from the lumen all the way out to the outer part of the colon, is involved, okay? And that's going to be different than what we see in ulcerative colitis. So this is going to be our first point to really draw a contrast between the two. Anywhere from the mouth to the anus can be involved in Crohn disease with skip lesions, meaning we will have one part involved and then you're going to skip and nothing will be involved. And then another part will be involved and then you'll skip and you'll have completely healthy normal colon. And then another part will be involved, okay? The most common area to be involved is the terminal ileum. I know, terminal ileum is not part of the colon, it's part of the small bowel, but whatever, we're including it here anyway. I really want you to remember, and I think you know this because you've told me this in the past, terminal ileum is really the place that all these Crohn's patients are going to have inflammation. Okay? And the rectum is the least common, and that's different from ulcerative colitis, which always involves the rectum. Okay? So our patients are going to present with right lower quadrant pain. Don't confuse it with appendicitis, right? We need to differentiate that because of that pain at the ileum. That's where the ileum is. It's really inches away from the appendix, and so it makes sense that the pain would look similar. And non-bloody diarrhea. I want you to remember this. Patients who have Crohn's disease, think about, so here's our colon. I never miss an opportunity to draw the colon, right? You can agree with that. So here's our colon. And here's our terminal ileum, okay? So if our terminal ileum has inflammation, say it even starts bleeding, that blood has to get all the way through our large bowel, all the way through, before it gets to the rectum. And so by that time, typically, it's not going to look like blood. If anything, it might look like a little bit of melena. But in general, your patients are not going to have a bloody diarrhea. They will just have a normal-looking diarrhea. Again, another difference between Crohn disease and ulcerative colitis. Excuse me. Granulomas are typical in Crohn's disease and not seen in ulcerative colitis. That's what's giving you this inflammation through the wall is a granuloma. Cobblestone mucosa, you can see here. This is kind of looking like stones, right? If you've ever been to Boston, I'm sure in Atlanta, in some of the old heritage sites, they have things like cobblestones there. And that's what that looks like. Strictures, you can see on imaging. A stricture is essentially just a narrowing of the colon. And so that's something that you can see. Your patient's going to have some malabsorption with nutritional deficiency. Remember, these patients have fatty stool, right? They have steatorrhea. They have some fatty diarrhea, these patients? No? They can. They can sometimes. They can sometimes because remember what we said about the terminal ileum. It's an important place for reabsorbing what that we need to break down fats. We have a circulation, right, that goes from the terminal ileum back to the liver for our bile acids. So bile acids, I'm going to write BA here for bile acid. We need to break down fat, okay? And so if we lose our terminal ileum is where we reabsorb our bile acids so that they can go back and start absorbing fat again. If we lose our terminal ileum, all of the bile acids are going to leave out the colon. They're going to leave out the rectum, okay? And so we're not going to be able to digest fat, so we are going to see some nutritional deficiency. Our fat-soluble vitamins we're going to lose, okay? We're going to have some kidney stones. Essentially, and this is really kind of getting a little more complicated, but because now we have a lot of fat in our colon, something called oxalate binds to the fat in our colon. Okay. Now that the oxalate is binding to fat in our colon, essentially in the kidney, we end up getting calcium oxalate stones. I know I'm not explaining this very well. I'm sorry for that. But essentially, because of the fat malabsorption, we end up with kidney stones. Okay. And these are calcium oxalate kidney stones that you can see in Crohn's disease. I'd like you to remember that patients with Crohn's disease can also present with kidney stones due to fat malabsorption. Okay? Okay, I know I'm not explaining it very well. The fat that is in our colon, it's going to bind to oxalate. If you don't have the right ratio of oxalate to calcium, then calcium oxalate ends up precipitating in our kidney and forming a stone there in our kidney. Okay, the oxalate would normally be reabsorbed back into our bloodstream, but it's not being reabsorbed into the bloodstream because of the fat there, and so that ends up causing kidney stones down the line. Okay. All right. So other things you can see, fistulas, which is a connection between the colon and any other organ or even the skin. And so you can have a fistula between the colon and the bladder. You can have a fistula between the colon and the vagina. You can have a fistula between the colon and the skin. And so, they would present in different ways. But something to keep in mind for these patients is that, if they're presenting with very bubbly urine or very stinky urine, consider a possible cause is that there's a fistula that's formed where stool is now leaking into the bladder and mixing with the urine. Okay. Other things we can see, ankylosing spondylitis, sacroiliitis, which is a component of ankylosing spondylitis, arthritis in different joints, erythema nodosum, which is these dark red spots that these patients get on their skin, and uveitis or inflammation in the eye. Inflammation in the eye is uveitis. Okay. Smoking is going to increase your risk of Crohn's disease, so do not smoke. And in terms of pathogenesis, all they can really ask you about is this nucleotide binding oligomerization domain containing protein 2, aka NOD2. We call it NOD2 because it's a lot easier to say than all this other name. But be familiar with this NOD2 as the mutation that leads to Crohn's disease. Okay? Questions on this one? No? Okay. Next is our ulcerative colitis. Now, for our ulcerative colitis, here's our normal healthy colon. In ulcerative colitis, rather than having that ulceration that goes all the way to the wall, here are essentially we just lose one layer of our colonic lining universally. Okay, and so it's not going to go all the way to the wall. It's just going to involve the mucosa and submucosa, and that's it. It's not going to make it all the way to the muscular lining of the colon. Okay, so you can see the difference. This has a nice juicy wall. This one, the wall is much thinner. Now, this is always going to begin in our rectum, and this is why we say these patients tend to present with bloody diarrhea. You're having the inflammation right above the anus. So yeah, it's going to have some blood in the stool when these patients use the bathroom. It can extend proximally all the way up into the cecum, and it's going to be a continuous involvement versus the skipping of ulcerative colitis. Of Crohn's disease. This is going to be left lower quadrant pain, which is different from Crohn's again, which was right lower quadrant pain, with some bloody diarrhea. We see crypt abscesses with neutrophils. Pseudopolyps can be seen. As you're looking at these areas, you can see that there's some areas where there's a little bit of normal mucosa left. This is what we call the pseudopolyp. It's not truly a polyp. It's actually just an area where there's normal stomach lining still. We're going to have loss of these invaginations of the wall. These are called haustra. And you can see our ulcerative colon here. It's completely smooth. And so if we do a barium enema, if we do an enema and shoot a bunch of dye up the colon, what we see is the lead pipe signing, where instead of instead of the dye, making the colon look like this with lots of nice little bumps, our colon is going to look like a lead pipe. It's going to look like this, okay? Because we've lost the haustra, and so it ends up having this lead pipe appearance. Okay. Some of the more important things about ulcerative colitis are these long-term complications. So toxic megacolon, and the big one is carcinoma. For these patients with ulcerative colitis, there's a high risk of developing colon cancer. And so 8 years after diagnosis, these patients need to have a colonoscopy. Okay. To look for any kind of polyps that look suspicious. Colonoscopy. Okay. And so in these patients, a colectomy or removing of the colon would cure them of ulcerative colitis. If you take out these patients' colon, they will never have another episode again. Why? Because ulcerative colitis only involves the colon. Unlike Crohn's disease, which can involve anything from the lips all the way to the anus, ulcerative colitis only involves the colon. If you take out their whole colon, they will not have any more problems. Okay? Ulcerative colitis is associated with primary sclerosing cholangitis, which is a form of liver failure. I'm writing LF for liver failure, and cirrhosis. And so that's another thing we need to keep an eye out for. And one sort of random thing is smoking is actually protective against ulcerative colitis. Not that you should tell all your patients with this disease to go smoke, but just sort of a strange thing about it that they'd like you to know. Okay? Good. So here I can kind of demonstrate for you how the inflammation of ulcerative colitis just progresses continually versus the patchy inflammation of Crohn's colitis. And you see here is a stricture, narrowing, and this is something else that you can see in Crohn's. You don't really see in ulcerative colitis, okay? Because Crohn's involves the entire wall. Okay, so before we move on, do you have any questions on ulcerative colitis versus Crohn's colitis? You said no? Okay, so I have a question for you. So I'm going to say some term relating to ulcerative colitis or Crohn's, and I'd like you to tell me whether that term is associated with ulcerative colitis or Crohn's colitis. Okay, ready? All right, this is the game show, okay? You're playing for 1 million imaginary points, so good luck. Okay, so first, skip lesions. Good. Abscesses. Sorry. Abscess is ulcerative colitis. For Crohn's, what we look for is granulomas. I'm sorry? Yes. Fistulas. Yes. Fistulas. Yes. Very good. Okay. So let's see. The NOD2 mutation. NOD2. NOD2 mutation. Crohn's, yes, very good. Primary sclerosing cholangitis. Yes, very good. And your final question is going to be, you have a patient with inflammatory bowel disease. You don't know if it's ulcerative colitis or Crohn's, but you see that they have bloody diarrhea. Which do you think that it is? Bloody diarrhea? So this is the thing, right? Ulcerative colitis, right? Because the inflammation is right there. Is right there. If you do a direct rectal examination of this patient, you are going to be touching the inflamed area, right? Your finger's going to come back with blood on it. Why? Because in ulcerative colitis, this area is very bloody versus Crohn's. The inflammation tends to be a little bit higher up, and we don't really see the blood as much. Okay? Excellent. So we are sending you home with the runner-up prize of 500,000 imaginary points. Congratulations. So, moving right along here, diverticulosis. Diverticulosis is outpouchings of mucosa and submucosa through the muscularis propria. If this is the normal bowel wall, a diverticula would just be a outpouching like this. Okay, so you can see that, this is an area where things can tend to get stuck, and if the opening gets obstructed with some, really hard piece of fecal matter, and this area is completely obstructed, this can actually progress to an infection, and we would call that diverticulitis. Okay, now diverticulosis, all that means is that you have outpouchings. Having outpouchings isn't necessarily, it's not this horrible, horrible thing, right? The only problem is when of those outpouchings gets obstructed. And so I want you to think of diverticulosis as being benign and diverticulitis as being really, really bad. Okay, well, not really, really bad, but something that would require hospitalization and treatment with antibiotics. Okay. So this is related to wall stress. So these little diverticula are going to accumulate in the colon as we accumulate birthdays. Older people have more of them. That's just the way of life. It's associated with straining, low fiber diets, and again, seen in older adults. This is something that is asked about. The diverticula itself arises where the vasorecta cross the muscularis propria, which is a weak point in the colonic wall. And so if we take a slice of the colon here, and then we look down on it from above, what we would see is here's the wall of our colon, here's our little diverticula, okay, and here is the inner lining of the lumen, okay, here's our little diverticula, okay, and so the area, so we have a blood vessel that comes in and feeds all of this, right? We need to have blood coming into our colon. It's very important to have blood here. The point at which the blood vessel merges here to give these branches is the area that the wall is going to be weakest, and this is where the diverticula will form. The area where the vasorecta cross the muscularis propria is where the diverticula form. Okay? Sigmoid colon is going to be most common location of diverticula. And this is important because the sigmoid colon, is that on the right side of your body or the left? The sigmoid. The sigmoid on the left, right? Yes. So when your patient has diverticulitis, where are they going to have pain? On the left, right? Because that's the most common place for these diverticula to form. And so when you have if a question stem on your step 1 exam is saying an elderly patient presents with pain in the left lower quadrant, and they describe to you a white blood cell count, everything. Essentially, the way I want you to think about diverticulitis and the patient presentation is that it looks like appendicitis, except it's on the wrong side. They're going to have a white count, they're going to have a fever, they're going to be very uncomfortable, and then they're going to have a little bit of pain when you press in on that left lower quadrant, and that's typically going to be, because of some sort of bacterial infection there of one of the diverticula. Okay. As long as it's not infected, it's going to be asymptomatic. The only symptom really is just going to be bleeding. So because we said that the merging happens right at the vessel, these diverticula tend to bleed a little bit. Okay, they're going to have a little bit of blood coming out. And that bleeding is going to be so common, actually, that diverticulosis happens to be the most common cause of lower GI bleeding. The number one cause of lower GI bleeding in adults is diverticulosis. Of course, any patient that comes in that's saying that I have blood on my toilet paper, you have to check them for colon cancer. But the most common cause is going to come out to be diverticulosis. Okay? Great. All right. Ischemic bowel disease here, imagine having angina except in your abdomen, right? So if you have some sort of occlusion of any of your major branches of these blood vessels, it's going to cause ischemia to your intestines that progresses to necrosis of that part of the bowel. Okay, and so here, say you have a patient with atherosclerosis. They're going to have, narrowing of many of the vessels in their body. Their coronary vessels are going to be narrow. The vessels in their brain are going to be narrow. And the vessels in their GI tract may be narrow as well. So think about the celiac, SMA, and IMA being narrowed. When these patients eat, their GI tract is going to require more blood. When their GI tract starts requiring more blood, that's when they're going to start to have pain. Okay, so it's kind of like angina. Think about it. When you have angina is whenever you start exerting yourself, your heart requires more blood, that's when you have pain. For these patients, whenever they eat, their GI tract requires more blood, that's when they have pain. Okay, so these patients present with abrupt abdominal pain associated with meals. They are going to progress to bloody diarrhea. As the bowel is dying, they're going to have vomiting, distension of their abdomen, and they may even ultimately die. All right, very serious condition here. Small intestinal ischemia, we're thinking about the SMA, and blood supply being vulnerable to interruption right there at the branch from the aorta. For colonic ischemia, SMA or the IMA, and keep in mind that watershed area at the splenic flexure. We always point out that area at the splenic flexure because it is a very important part for losing blood supply. Okay, so splenic flexure, if this is our colon, right? Here's our rectum, colon. Our splenic flexure is right here. And this is where the cutoff goes. So the IMA is supplying blood from this direction. The SMA is supplying blood from this direction. And this area here is sort of the shared blood supply of both. Neither artery gives a good supply to that area, but they both give kind of a weak supply, and that happens to be enough. However, if you have some sort of obstruction in your SMA, now this area is going to be lacking blood supply, and this is going to be one of the most common places for ischemia. Okay? Any questions on that? No? Okay, great. And so mucosa is going to be most susceptible to ischemic injury. The musculature is least susceptible. And so if you get a little bit of ischemia to your mucosa, it's not good, but if you address the underlying cause, you get your patient taking a statin to lower their cholesterol or something like that, that mucosa is going to come back. Okay, versus if you start to lose the muscle, well, that part of the bowel may not come back and you may need to go surgically remove it. Okay. Great. Angiodysplasia. This is our second leading cause of lower GI bleeds. We talked about this before, being when an elderly person has a growth of vessels in their cecum or right colon that's just abnormal. Okay, and so it's just sort of an unlucky thing. It's not really associated with anything other than age, where a bunch of vessels that have very weak walls start growing out in the colon. Okay, and then these vessels, they have weak walls, they tend to bleed, and so our patients will present. They're going to say, I found some blood on the toilet paper after I wiped. You're going to say, oh no, oh my God, cancer. And you're going to get a colonoscopy to look for cancer. You're not going to see any cancer. You're going to say, oh my God, okay, well, since I ruled out the scariest thing, let me think about the most common cause of lower GI bleed, diverticula. So you're going to go on the colonoscopy, you're going to look for diverticula. Oh my God, no diverticula. Well, the second most common cause of lower GI bleeding is angiodysplasia. So you're going to go with your colonoscopy, you're going to look around, and eventually you're going to see something looking like this, except it's going to be bright red. and that's going to be your angiodysplasia. It's just an area of blood vessels that have grown, they have weak walls, they're bleeding into the lumen. Okay? Hemorrhoids, swelling of the internal or external tissue around the anus due to persistently elevated venous pressure within the hemorrhoidal plexus. So, people that strain when they defecate, pregnancy, portal hypertension, secondary to cirrhosis or liver failure, right? When you have cirrhosis, we talked about how having cirrhosis causes elevated portal pressure, and that leads to varices in 3 places. Do you remember what those 3 places are? That's okay. It's okay. Don't be hard on yourself. So, umbilical. Yes, very good. Umbilical. And then the R is for rectal for our hemorrhoids, right? Rectal for hemorrhoids. And then P stands for portal hypertension. Okay, so last thing is the E for the last place that we see varices. Esophagus, very good. Esophagus. And so this is the one that we really worry about, because if those rupture, your patient can bleed out. And, anything can really rupture them. If they swallow a chicken bone, I don't know about your family. My family likes to chew on chicken bones. I think it's like, they get more flavor out of it. I don't know why they do it, but they do it. So swallowing one of those chicken bones, if you have those dilated veins in your esophagus, boom, you can rupture it and bleed out pretty quickly. So that's the one we really worry about. Okay? Very good, very good. So next we can talk about these polyps. I keep mentioning polyps. What the heck are polyps? So polyps, all they are growth of tissue within the colon, within the lumen of the colon. Okay, here's our colon. Here's the lumen. A polyp would just be some sort of growth of tissue into the lumen of the colon. Okay, it can be neoplastic or non-neoplastic. The way that we characterize them are as flat, sessile, or pedunculated. Flat means we would have a lesion. If we're just looking at the inner lumen, the lesion would just be flat like this. Okay, so you can see how this lesion would be easily missed, a flat lesion like that. Sessile means it's sort of S-shaped. Sessile kind of means it comes up and down like this. And pedunculated, you can think about a mushroom. So pedunculated, it kind of grows out and it has a stem. Okay, so those are our 3 major types of polyps. Okay, and so when we take a biopsy, we can further differentiate them. The first type is hyperplastic. This is going to be the most common kind of polyp. Someone gets a colonoscopy, they have a polyp removed. You're hoping it's this type. All it is a growth of a little bit of extra tissue, just a little bit of extra colonic tissue that grows in an upward fashion rather than a sideways fashion. You remove it, it doesn't come back. It's pretty common. It's non-neoplastic. There's no risk of it metastasizing or anything like that, and they're generally pretty small. Hamartomatous. When you see hamartomatous, think about bloody. Okay, bloody. These are generally non-neoplastic. They're generally found just a single solitary lesion. They don't have risk of malignant transformation, and they are associated with Peutz-Jeghers syndrome. In Peutz-Jeghers syndrome, these are the people that present with the discoloration on their lips, as Peutz-Jeghers syndrome, and they also have these growth of very bloody polyps. Hamartomatous means bloody polyps. Okay. Adenomatous, these are neoplastic. Okay, so they have some sort of mutation that's causing a pathologic growth of cells. So mutations in the APC and KRAS genes. This is important to memorize. And the histology, that you're really scared of seeing in these types of polyps is called villus histology. Villus histology is what you look under the microscope and what you see. When it's called villus, that is a more aggressive type of cancer. Okay. May present with occult bleeding. And then last is the serrated type. And so this is sort of like our sessile type of polyp. These are pre-malignant and are associated with CpG hypermethylation mutations, microsatellite instability. You remember our MSH1 repair enzymes that repair microsatellites, CpG islands and things we talk about in biochemistry. This is the condition. Okay, up to about 20% of cases of sporadic colorectal cancer. So, screening for polyps is performed by colonoscopy. We also do a test for fecal occult blood, and you'll also hear that called guaiac. Guaiac, stool guaiac. Guaiac means digested blood, essentially, and so that's another way we can test for blood in the stool. If we don't see bright red blood, but we think it's there, that's how we test for it. Polyps are usually clinically silent, but they can bleed. And so the goal of a colonoscopy is to remove any adenomatous polyps before they turn into cancer. Okay. Adenomatous polyps are dysplastic. They're not normal. They have some sort of mutation that's causing them to have a lot of mitosis and increase in number rapidly. And again, villus adenomas have the worst prognosis. I want you to think of a villus villain, right? The bad guy in the movie is the villus adenoma. I have seen questions that ask you, of the following types of polyps, which has the worst prognosis? You need to know that villus adenomas have the worst prognosis of all of the colon adenomatous polyps. Okay? Okay, so what we are looking at here is the histology slide of a biopsy of a polyp removed from the colon. Now, what I would like you to notice as you look at this is that essentially the architecture looks pretty close to normal. What do I mean by that? Well, when they do a staining, if there's a lot of extra cells, the stain looks very, very purple. It looks dark, dark purple. And to me, this doesn't look too dark purple. It looks kind of pink. There are little tiny dark spots here and there, but in general, the color here looks pretty normal. That's the first thing. The second thing is that the space in between individual villi looks pretty normal. Looks like there's a sufficient space in between the villi. The only thing that looks abnormal to me is just how many there are. It looks like there's a lot of villi all over the place, right? If you just look at this, there's just so many villi all over the place. And so it turns out what this polyp is called, this is called a hyperplastic polyp. This is the type of polyp that is not malignant, it's not adenomatous, it's not neoplastic, it's just basically a growth of extra tissue. And so this is why we call it just a hyperplastic polyp. Okay? Great. Next, we have another biopsy. And what you can notice on this biopsy is that we have what looks like normal tissue here. This looks like normal tissue. And then looking at this purple stuff, this dark, dark purple looks abnormal. Okay? And so on the last slide, when I was describing, that it didn't look too purple to me, this is what I mean. So normal colonic tissue kind of looks pinkish when you stain it. When you have some sort of neoplasia, some sort of pathology, it turns purple like this. Okay? Great. And so this is called our sessile adenoma. It's flat right along the surface of the colon, and it has this pathological appearance where it's got that very dark purple color. Okay? Great. These villi do not look normal to me either. Number one, they look very dark, very purple, which is what we said before is something that we said looks abnormal. And then the villi themselves look very narrow. They look like a narrow, skinny, kind of like this Waluigi. Look at Waluigi here. He's very narrow, very skinny, very dark purple. Waluigi is the enemy of Luigi. And you know Mario and Luigi, right? Mario Brothers? So Luigi is the good guy. Waluigi, you can see with the upside down L, is the bad guy. Okay, he's the villain in that particular story. So we're going to call this a villus adenoma. Villus adenoma. Very narrow, skinny villi. Gives us a villus adenoma. And again, this has the worst prognosis of all of the polyps. If you only learn one thing from the previous, however long I've been talking about polyps in our colon, if you only remember one thing, please remember this. The villus adenoma polyp has the worst prognosis. Okay, that's probably the most important point you can remember. Okay? Great. So in terms of our diseases, our congenital diseases that lead to colon cancer. The first is familial adenomatous polyposis, FAP. I'm sure you remember this from medical school. It's an autosomal dominant disorder, and what we see when we do a colonoscopy is hundreds to thousands of adenomatous colonic polyps. Okay, I'm not talking about that little hyperplastic polyp that we talked about that's completely fine and non-neoplastic. I'm talking about adenomatous polyps, those kind that are actually neoplastic. All right, the entire colon is lined with them, literally lined with them. This is due to an inherited mutation in APC. This is important. I'm going to put a star here. This increases the propensity to develop adenomatous polyps throughout the colon and rectum. And so for these patients, we remove the colon and rectum prophylactically. Otherwise, all of these patients are going to develop cancer by age 40. And so for most of these patients, we'll wait until they make it through high school, and maybe, you know, if they're going to college, wait till they maybe finish their first few years of college. And then the risk is just kind of too great. You just take out the whole colon. Because at the end of the day, you can't go in there and biopsy 1,000 polyps, right? That is so many polyps. Like you would just kind of lose track looking for your cancer. And so what you do is you wait until you want them to have a nice, you know, high school years without having to have the, you know, colostomy bag and all that kind of stuff. And then to prevent their risk of cancer, you just take out the colon. Okay. Now, if you take this entire condition I just described to you, lots of polyps, high risk of cancer, take out the colon, you take all that, and then you add in fibromatosis and bone tumors, that is going to give you your Gardner syndrome. Gardner syndrome is just FAP plus bone tumors and tumors of fibroblasts, giving you tumors of fibrous tissue, essentially, in the abdomen. Okay. If instead we take FAP and then we just add in some central nervous system tumors, that's going to give you Turcot syndrome. Okay, so Gardner syndrome and Turcot syndrome, I want you to remember these as a colonic polyp disorder. That's primarily what they are. You're just taking the colonic polyps in Gardner and you're adding bone tumors. In Turcot syndrome, you're taking those colonic tumors, those polyps, and you're adding CNS tumors. Okay, and so how are you going to remember this? For me, for Turcot, that kind of reminds me of a turban, right? Turcot kind of sounds like turban, right? Turban you wear on your head. That's where your central nervous system is, right? And so Turcot syndrome, I think of turban syndrome, and so that is CNS tumors. For Gardner syndrome, for this, I just always thought of a gardener who's out on his knees in the garden all the time and then getting tumors in the bones because he's on his knees. Okay, he's a gardener, he's bending down on his knees, he's getting bone tumors. Okay, that's how I remember those two, because otherwise I never would be able to remember it. And you know I always have these stupid ways of remembering things, so if that works for you, awesome. Okay. Next type of colon syndrome is going to be our hereditary non-polyposis colon cancer. You may also hear it called Lynch syndrome. You may also hear it called HNPCC. This is our most common cause of hereditary colon cancer. And so what we see here, this is a colon cancer. However, these patients do not have all the polyps that we saw in FAP. That's the big difference between our hereditary non-polyposis colon cancer and FAP is the presence of polyps. These patients get colon cancer, but they don't have those thousands and thousands of polyps that we saw in the previous slide. Okay, it's going to be most often right-sided cancer, and typically it's due to a mutation in our DNA mismatch repair enzymes, MLH1, MSH2, MSH6, PMS2. Have some idea that it's associated with this. I think that this is important to know. HNPCC is due to a mutation in DNA mismatch repair enzymes. Okay? And so you have increased risk of cancer both in the colon as well as endometrium, ovary, small bowel, urinary tract, and brain. Okay? So if you get a woman with colon cancer at age 50, what do you screen her for next? Endometrial cancer. You're really concerned because of that strong connection between Lynch syndrome, aka HNPCC, and endometrial cancer. Okay, great. So, presentation-wise, when our patients are coming in, patients never come in and say, "Hey, doc, I have cancer. It's on the left side of my colon, right about the side part of my sigmoid. It's probably a villus type." That just doesn't happen. So we need to be able to recognize when our patients come in, what is different about their presentation. They're going to complain about different things. The two things that they're going to complain about, they're either going to complain about constipation or they're going to complain about bleeding. Whether they're complaining about constipation or bleeding will tell you about what side of the colon the tumor is on, believe it or not, okay? And so, how can I say this? Well, let's go ahead and draw the colon. Why not? We love drawing the colon. So here's our colon. Now, if we have a tumor that is on the left side of the colon, right here at the sigmoid, right? One big honking tumor, okay? All tumors bleed. Whether it's on the right or left, they're going to bleed. And so if a patient has a big tumor right here on the left side of the colon, they're going to present complaining about bleeding. There's going to be blood in their stool. When they get up after using the bathroom, they're going to see blood there in the toilet, or when they wipe, they're going to see blood on the tissue paper, and that's going to cause them to come in. Okay? So that's for our left-sided cancer. Now, if we have a tumor on the right side, the problem is, yes, it's going to bleed, but all of that blood is going to be digested. And so by the time that it reaches our patient's stool, when they turn around and they look at the toilet after using the bathroom, they're not really going to notice any different. Maybe it looks a little darker, but I mean, who really keeps track of how dark their poop is? Most of us, not really, right? And so they're not really going to realize they're bleeding. So this tumor is going to continue to grow, continue to grow, continue to grow. Now it's obstructing the colon. Now this patient is constipated. And so, rather than presenting saying, "Doc, I'm bleeding," they're going to say, "Doc, I'm constipated." And so this is our big difference in the presentation between right and left-sided colon cancers. Right-sided colon cancers obstruct and cause constipation. Left-sided colon cancers bleed. Okay? It really is that simple. Right side obstructs, left side bleeds. Okay? Excellent. Great. So, moving away from the colon, any last minute questions on the colon before we go back into our hepatobiliary system? That's how you said no? They're good? Okay. Great. So, gallbladder pathology. Gallbladder is here right below our liver. The gallbladder, we talked about it before. Its job is to store lots of bile acids. It has some cholesterol in there, phospholipids, all of the conjugated bilirubin that we're trying to get rid of. It's all stored there in the gallbladder. Now, all of the cells of these hepatic ducts, left hepatic duct, common hepatic duct, cystic duct, all of the cells lining these ducts are full of two enzymes, alk-Phos and GGT. If you have a patient that presents with an elevation of alk-Phos and GGT, you should be concerned for damage to bile duct cells. Okay, these are the two enzymes you look for to point towards biliary system pathology, which I'm sure you're comfortable with that idea. If you instead had damage to liver cells, hepatocellular cells, that would cause an increase in your transaminases. Your ALT, AST would be elevated. Okay, and so there's a bit of a difference there. I just kind of wanted to point that out. Damage to liver cells cause increases in your AST, ALT. Damage to bile duct cells cause elevations in alk-Phos and GGT. Okay. So let's talk about different pathologies here. Cholelithiasis, so gallstones. Here we have a precipitation of cholesterol or bilirubin in the bile. Okay, either supersaturation, decreased phospholipids, stasis of the gallbladder. It's not contracting for some reason. All of these things can lead to stones. So what are the different types of stones? The most important one is going to be our cholesterol gallstone, right? This is our most common, especially here in the West. A lot of fatty foods, and that leads to high cholesterol. And so these yellow stones, they're radiolucent, meaning you cannot see them on X-ray, you cannot see them on CT scan. You need an ultrasound to be able to see the stones. Okay. The classic mnemonic for remembering who gets these stones is your 40s female due to the elevated estrogen. Estrogen actually causes your gallbladder to stop contracting. Elevated estrogen causes your gallbladder to stop contracting. So it's not going to be ejecting what's inside. Everything that's in the gallbladder is going to start coalescing and forming stones. 40s female, fertile, giving you that estrogen as well. Fat, and then Crohn's disease, we have that decreased bile acid reabsorption. Boom, another manifestation of that terminal ileum problem. In Crohn's disease, we have inflammation of the terminal ileum, decrease of reabsorption of bile acids. That gives us the fatty stool, decreased fat-soluble vitamin absorption, as well as gallstones. Bilirubin gallstones, on the other hand, these are made of calcium plus unconjugated bilirubin. So you will be able to see these on X-ray very clearly or CT scan. Risk factors, really anytime your patients have breakdown of red blood cells, they have a risk of bilirubin gallstones. An infection of the biliary tract with a bacteria can increase your risk of bilirubin gallstones, as well as some different parasitic worms. So your Ascaris lumbricoides. We're going to talk more about this during our microbiology lecture. This is a roundworm that infects the biliary tract and blocks the duct. Our Clonorchis sinensis infects the biliary tract, leads to cholangitis, carcinoma, and so those can both lead to bilirubin gallstones as well. So we have a stone in our gallbladder. Who cares? What's the big deal? Well, the big deal is that stone can go to the, our gallbladder is shaped like this. It's got this nice narrow neck. People love a narrow neck, but the gallstone can come up here into this narrow neck and obstruct it. Now, whenever we have an elevation of CCK, what does CCK do? So I heard you say it stimulates the gallbladder? Oh, you forgot. No problem. That's okay. So essentially, it's going to stimulate the gallbladder just to contract. It's just going to stimulate the gallbladder to contract. And so when the gallbladder contracts, it's going to push this stone into the neck. Now it's trying to push against the stone in the neck. Pressure is building, and ultimately, you're going to end up with a lot of inflammation. Okay? And so with these patients, they are going to have pain when this happens, and the pain is going to be colicky, meaning the pain comes and goes. Whenever the CCK gets elevated, the gallbladder contracts and we get the pain. CCK is going to drop after a minute or two, and so the pain will go away. Okay? And so we call that a colic pain, a pain that comes and goes. Okay? Great. And so biliary pain as the tract is trying to get the movement past the obstruction. Cholangitis can happen as you have inflammation of the bacterial infection downstream, right? We have an obstruction here. If there's any bacteria in this area, that they can manifest an infection. And so that's something we can look for. Cholecystitis. This is an obstruction of the neck of the gallbladder where we end up needing to remove the gallbladder. And this is a classic presentation. Obstructive jaundice means that the stone, rather than obstructing here at the neck of the gallbladder, is obstructing down in the area that where the cystic duct and the common hepatic duct join. Now, any bilirubin coming down from the liver, it cannot go into the gallbladder and it cannot leave the GI tract. And so these patients end up with jaundice because we've completely blocked the body's ability to get rid of bilirubin at this point. Okay? So good. Elevated alk phos, again, elevated GGT. And other things that we can also see is pancreatitis. If the stone is at the ampulla vater, it's going to block not only the secretions from the liver, but also the secretions from the pancreas. And that can lead to pancreatitis. Okay. So just to kind of to cover this again, I'm drawing the gallbladder. Okay. Gallbladder has our cystic duct. It's going to join the right and left common hepatic ducts here and form the common bile duct. The common bile duct is going to join with the pancreatic duct here. You can imagine they're joining. And here is the duodenum coming around. Okay. This is the ampulla of Vater here. Here's our pancreas. Okay. Nice. Work of art, if I may say so myself. So, imagine that we have a stone that sits right here at the neck of our gallbladder. Okay? Now, if we have a stone that sits there at the neck of the gallbladder, what is our patient going to look like, Natalia? What are they going to complain about? And how are they going to look? So, I'm glad you said that. They would not have jaundice, and I'm going to tell you why in a minute. But what else would you look for? Good. Vomiting pain. Mm-hmm. Good. And where would they have pain? Where exactly in their abdomen? Good. Yes. Especially in the right upper quadrant. So one of the things that we look for is Murphy's sign. Murphy's sign is when we press up under the liver, trying to get our fingers under the liver, and our patient has pain there. That's our Murphy's sign. That is a sign for a cystitis, acute cystitis. Okay. Good. So why don't we have jaundice, though? You suggested jaundice, and it would make sense because we have a blockage. But why don't we have jaundice? Well, in order to have jaundice, we need to have a complete obstruction of bilirubin's ability to leave the body. And so here's our conjugated bilirubin up here in the liver being made. I didn't really draw our liver. I'll add it in right here just for effect. And so here's our conjugated bilirubin. It's coming out through the hepatic duct here. It wants to get into the gallbladder. It can't. It can't get there, and so bilirubin is just going to leave out through the duodenum. So we don't have a complete obstruction. Bilirubin's able to leave. Our patient would not get jaundiced. Okay? Does that make sense? Let's compare that to if we had a block a little bit. Oh, did the whole thing just disappear? Oh my God. That's unfortunate. Okay, so I'm just going to quickly redraw this. Okay, great. It's not going to be as pretty as before, unfortunately. Okay, great. Pancreas. Yep. And duodenum. Okay. All right, great. And so, again, this is our gallbladder. Here's our common hepatic duct here. And so, if we had a stone here in the common bile duct, what would happen is, here's our conjugated bilirubin. It wants to leave. It goes into the gallbladder. Great. I can hang out in the gallbladder. Now, the gallbladder contracts. Okay, I want to leave the body. Boom, I get hit with this obstruction. Where do I go? Well, I have to start accumulating. I accumulate, and eventually this patient gets jaundiced. Okay? And so this is something that the USMLE exam is going to make sure that you understand, is that when do you get jaundice and when do you not get jaundice in the context of stones. Okay? If the stone is here, you would not get jaundice. If the stone is here, you would get jaundiced. Now, what if instead the stone was here at the ampulla of Vater, blocking the ampulla of Vater? Would you get jaundiced? Oh, I did not mean to do that. Sorry about that. Yes, so here's our common bile duct. Here's our gallbladder. Here's our hepatic duct. Okay. Pancreas. Pancreatic duct. Joining at the ampulla of Vater at the duodenum. Okay, here's our duodenum. Okay, great. So my question was, if we have a stone here at the ampulla of Vater blocking both the common bile duct and the pancreatic duct, would we have jaundice? Yes, we would, because bilirubin cannot leave, so we would have jaundice. What else would we have? We're blocking pancreatic enzymes from leaving, right? So what might happen to the pancreas? Inflammation, pancreatitis, very good. And so those are the three things you need to know from this biliary stone talk. Stones here do not cause jaundice, but they do cause Murphy's sign, M-U-R-P-H-Y, Murphy's sign. Murphy's sign is when you press up on that right upper quadrant of your abdomen and you have pain, and that is a sign of a stone here obstructing, giving you acute cholecystitis. A stone here gives you jaundice. Typically, the gallbladder is painless if the stone is here. And then if the stone is all the way down at the ampulla, you have jaundice as well as pancreatitis. Okay? Questions? None? Excellent. You're doing a great job. So, acute cholecystitis, again, it's an inflammation of the gallbladder wall. It could be due to bacteria. Often there's no bacteria there. And it's different from appendicitis, where it's due to bacteria. Here, it's just more about obstruction of the neck of the gallbladder. When we take the stone out, we see an enlarged gallbladder with discolored wall of the gallbladder. Different types of cholecystitis. Gangrenous means we have some necrosis of the wall, destruction of the wall. And so this is going to be a very black gallbladder that's prone to rupture. Another subtype of cholecystitis is acalculous cholecystitis, where we have ischemia that causes a death to the nerves in the wall of the gallbladder, and so we end up with stasis, and that leads to cholecystitis. Okay. Clinically, again, we want that colicky upper abdominal pain. It may radiate to the tip of the right scapula or shoulder. These patients are going to be intolerant of fatty food because the gallbladder cannot emulsify those fatty foods, okay? Again, Murphy's sign. This is a 2-star sign. Pain on inspiration. When you're pressing up on that right upper quadrant, you're going to say, take a deep breath in. When they take a deep breath in, they have pain. And so that is your Murphy's sign. Okay? Great. So in the acute inflammation, you're going to see neutrophils, cloudy or turbid bile inside of the gallbladder when you open it up. And if you don't take the gallbladder out, some of the complications include empyema, which is pus inside of the gallbladder. If you have some sort of rupture of the gallbladder itself, that can lead to peritonitis, okay, which is very painful, and it's essentially due to all of the contents of the gallbladder spilling out into the abdomen. Okay, cholecystectomy is the easy go-to treatment and can be performed laparoscopically. If your patient does not have their gallbladder removed, the big risk is that you can develop chronic cholecystitis. And so you can see that the wall of this gallbladder here has become pretty stinking thick, very thick wall gallbladder. This looks like a chronic cholecystitis. So repeated bouts of acute cholecystitis, look for a thick wall with gallbladder stasis. Histopathologically, the term you need to be familiar with is Rokitansky-Aschoff sinus. That's what you can see here. And it's just basically where you see a little bit of mucosa that's coming down into the wall of the gallbladder. It's just one of the histological signs that they make you memorize, unfortunately. The wall of the gallbladder eventually starts to get calcium inside. And when you look at their gallbladder on X-ray, it's going to be this bright white gallbladder looking at you. And so we call that a porcelain gallbladder. Okay? And so, it's very pretty. You get this nice porcelain gallbladder on X-ray. So what's the problem with it? What's the big deal? Porcelain gallbladder has a huge increased incidence of carcinoma of the gallbladder. Okay? And so you really need to take this gallbladder out already. You should have done it on the first bout of cholecystitis they had, but if you didn't do that, you need to take it out now. If you see a painless palpable gallbladder, think about cancer, either of the gallbladder or of the pancreas. Okay? And typically these patients are a little bit older. Okay, great. So moving on to the pancreas here. Acute pancreatitis, in terms of causes, the most common cause in females is going to be gallstones. So when we have that gallstone that gets out of the gallbladder, that goes through the common bile duct, that gets to the ampulla, then it's causing pancreatitis, like you told me before. In females, that's your most common cause. In males, it's alcoholism. Why? Males are stupid. And so they drink too much and they end up getting pancreatitis. Okay? So acute onset, mild, severe epigastric pain that radiates to the back. You'd be surprised how high yield this is. If the question stem is telling you about a patient with epigastric pain radiating to the back, that's pancreatitis. You're already halfway to answering your question if they've told you that. You'd be surprised how high yield that is. Not many other things cause that. Not many other things radiate to the back with epigastric pain, okay? So definitely, I'm going to put 2 stars by that because it really helps you in not being confused. Abdominal pain is just one of those complaints that, a patient will come in complaining of abdominal pain. It's like, okay, well, you probably have one of these 50 different things. Now I need to figure out which of those 50 it is. And so if they give you something like radiating to the back, boom, you've just cut your list down to about 5 different things it could be. Okay, all involving the pancreas. So the pain is from inflammation and necrosis. What do we look for in terms of labs? First is going to be amylase. The first 24 hours, we're going to see a big increase in pancreatic amylase. Then, as our patient continues and starts recouping, what we want to test for is lipase. This is actually more specific. This is the better thing to test for than amylase, okay? I don't think that they would give you both of these as options. Say they gave you a question, they said, okay, you have a patient and you think they have pancreatitis, what do you want to test for? chances are they're not going to give you, and option A is amylase, option B is lipase. They would give you either amylase or lipase, okay? Because they're both things that you can test for. But if they were going to get like that, if they're going to get dirty, then what you need to know is amylase is first. So they would have to say, your patient developed pancreatitis 3 hours ago. What do you test for? And then you would answer amylase, because amylase is better for the first 24 hours versus your patient got pancreatitis 4 days ago. What do you test for? Then you would select lipase. Does that make sense? Yeah. Okay, great. Other things you can see, low calcium, as calcium tends to bind onto the inflamed pancreas. Hyperglycemia due to destruction of the beta cells, which are responsible for producing insulin, of course. Jaundice due to obstruction from the stone in the CBD we talked about. Okay, so pathogenesis of acute pancreatitis, you need to know this. Activation of trypsin. Trypsin is the enzyme activator. Trypsin goes around activating every other enzyme. So it activates, a lot of different enzymes that can break down the pancreas. Okay. This leads to a sinner cell injury, release of kinin. This can start to cause clotting throughout the bloodstream. It can result in DIC, disseminated intravascular coagulation. It can result in shock for your patient. Patients can get very, very sick. Patients can die from pancreatitis. And so it's a pretty serious condition. It is another cause of ARDS as well. Acute respiratory distress syndrome, which we talked about during our pulm lectures not that long ago, right? We talked about ARDS. Pancreatitis was one of our causes of that. Okay. Great. Our causes of pancreas, it's a pretty fun mnemonic to memorize. If you can't memorize it, at least read it over frequently so that you're familiar with the causes. Even if you don't memorize it and write it down every day, that's okay. Just know these causes. So the mnemonic is I get smashed. And what it stands for is idiopathic, meaning just a random pancreatitis. We don't know the cause. Gallstones, we already know how that works. Alcohol can cause it. Ethanol, alcohol, right? Trauma, especially a patient who is in a motor vehicle accident, that they have a seatbelt on. That seatbelt presses on their abdomen during the accident and presses on the pancreas. Or they're driving and the steering wheel hits them in the abdomen, compresses the pancreas. That can cause pancreatitis. Patients on steroids. This is not like prednisone steroids. This is like bodybuilder, Arnold Schwarzenegger steroids can cause this. Mumps, autoimmune disease. Scorpion sting is super common. Not. Actually, I will tell you sort of a side story. I know we're running out of time here, but I'm from San Antonio, Texas. And in San Antonio, we do have scorpions. Not all over the place or anything like that, but you do sometimes see them. And so the way we would always have to be careful is whenever it was Christmas time, even though we don't get snow in Texas, we would like to put up the lights. And so you go get the box of lights from the garage. You bring the lights inside of the house. Before bringing them inside of the house, you would have to take the lights outside in the grass and shake them out, because sometimes there would be scorpions inside. And so you shake out the lights in the grass, and then you'd see a couple little scorpions fall, and then you could bring the lights into the house. I was never stung by a scorpion, and these were not big scorpions, right? They're little tiny baby ones. But if I was stung, perhaps I would have gotten pancreatitis. I always think about that. Hypercalcemia, hypertriglyceridemia. This is one that kind of gets glossed over. Any patient that has those high calcium levels can get pancreatitis. High calcium levels can get pancreatitis. Remember that. High triglycerides can get pancreatitis. ERCP, this is one of our ways of diagnosing different problems in the biliary tract. It involves colonoscopy. It involves dye. When you shoot the dye into the biliary tract, the pancreas can get irritated. And so that's our ERCP. certain drugs, sulfa drugs, and some of the drugs we prescribe for HIV/AIDS, which are NRTIs and protease inhibitors, can both lead to pancreatitis. And so that results in your eye gets smashed mnemonic. Ta-da! How do we diagnose pancreatitis? We need 2 out of 3 criteria, and it is a clinical criteria. So acute epigastric pain radiating to the back. I told you that's important. We can just use this by itself as half of the way, 50% of our way to diagnosis is just that pain. Can you believe that? Just that pain that radiates to the back, 50% of the way to the diagnosis. All you need after that is amylase or lipase and imaging findings. So when you do a CT scan, I was about to draw a CT scan. That's not possible. But when you do a CT scan, you will see the pancreas just looks, it doesn't have very clear edges or clear margins. Oh, there's a picture. Beautiful. So here is our normal CT scan. You can see the edges of the pancreas. It has this nice feathery appearance, and the edges are very clear, right? You can see where the pancreas starts and where it ends. And so this is our pancreas. I'm sure you know this already, but I'm outlining it for you. Okay, that's our pancreas. You can see the edges are very nice, very clear. What are these things, by the way? These 2 things hanging out here. Kidneys, good. What about this thing? The what? How do you say it in Spanish? Oh, yes, the spleen. Yes, very good. And then this is the liver over here, right? Good. And what is this thing right here? Is that like an abscess or something? What is that? Okay, good. Good. And then, so we can see in pancreatitis, the edges, those nice edges are gone, right? So number one, our pancreas looks a lot fluffier. It looks a lot bigger, thicker, widened. And then you can see this grayish area. This is all going to be what's called fat stranding. And so all of that inflammation is causing the fat around the pancreas to become more inflamed and start causing connections to the other organs and really kind of lose those nice clear borders that we see in normal pancreas. Okay, and so I include these pictures because I had a question on step 1 similar to this, and so I wanted to make sure I left that in there. Okay. Okay, great. Chronic pancreatitis, again, middle-aged alcoholic males, they do not learn the lesson. They get repeated bouts of mild to moderate pancreatic inflammation, same type of back pain. However, now, instead of just having the pain, now they're having other types of symptoms. So they're losing the exocrine in endocrine functions. Look for malabsorption, pancreatic insufficiency, diarrhea, loss of fat-soluble vitamins and steatorrhea, maybe some diabetes, increased serum amylase, and then great. So it may even lead to a pseudocyst, which essentially is just a cystic space with a wall of fibrosis around it. It does not have epithelial lining, so it's not a real cyst, but it's just sort of this fibrous lining with just inflammatory material inside. And it can happen to anyone who's had pancreatitis, but especially these patients with chronic pancreatitis. Okay. Any questions on this? No? Okay. I have a question for you then, before I let you go for the day. We have a patient with chronic pancreatitis, and we want to confirm that there's no intestinal problem going on. So we do a Dxylose test. Would these patients have a normal or abnormal Dxylose test? Yes. You got it. I am so happy.